This program is brought to you by Emory University.
Welcome, everybody, to Friday Morning Fellows Conference. As you can see, our speaker this morning is Will Maimo. Will is one of our first-year clinical track fellows. Will's originally from Cameroon, moved to the United States when he was, I think high school, right, Will? High schoolish?
After high school, actually.
Yeah. Moved to Georgia, ended up going to medical school at Case Western and then Vanderbilt for his internal medicine residency. And as you can see, he's going to talk to us today about amiodarone induced thyroid dysfunction, an important topic. So thanks, Will.
All right, thanks, Dr. Williams, for that introduction. As some of you guys know, my name is Will, first year clinical fellow. I don't have any disclosures, so I'm just going to go right to the case. So this is a gentleman I saw not too long ago who was admitted mid-March of this year for hypertension. He was hospitalized not too long ago for decompensated heart failure at an outside hospital. He received aggressive diuresis, and he presented to us because he was hypertensive. On review of systems, he actually denied having any sort of symptoms of heart failure, whether it was shortness of breath, orthopnea, or chest pain. But he did note that he had had about a 30-pound weight loss in the last 3 months. In terms of his past medical history, this gentleman was diagnosed with paroxysmal atrial fibrillation back in 2018. It was quiescent. But in July of 2021, he started having symptoms with AFib, having fast heart rates, and he underwent a cardioversion in July of 2021. But he later on presented in November. Now, bear in mind, once this guy was cardioverted, he was just managed medically with rate control. But in November, he presented again, having more episodes of symptomatic atrial fibrillation. The decision was made by the cardiology consult team at that point in time to start him on amiodarone in November so as to give him a load so that he could be cardioverted again. And in December of that year, he was cardioverted and had remained in sinus rhythm since. Other notable medical history is that he had a stent back in 2018. He has salt-sensitive fluid retention, and other comorbidities are hypertension, insulin diabetes, CKD4, and glaucoma. He's also a little bit obese, and he uses a CPAP at night. I'm sorry, he's morbidly obese, BMI of about 40. These are his relevant medications in terms of his heart medications. And he also has a non-cardiac medications associated with his comorbidities. When he presented to us in mid-March, sorry, I don't know if you can see that. Most of his labs were stable. He has acute and chronic anemia. White count was normal, platelets were okay. His BNP, his creatinine was elevated on presentation. Bear in mind again that this is a guy who was hospitalized for heart failure, was diuresed, and he presented to us hypotensive. His troponin was not, this is the old troponin system, not the high sensitive troponin, but it did not seem quite elevated and it was consistent with prior troponins. His BNP on presentation was not that significant as he had had higher BNPs in our system. But what was notable on that presentation was his thyroid levels where his TSH was undetectable. He had a slightly elevated T4 and his T3 was low. But when you look back in the system, just prior to initiating amiodarone, he had maybe borderline low normal TSH. And even earlier on in the year, his TSH was normal. So which brings me to the topic of today, which is amiodarone-induced thyroid dysfunction. For us to go over this, we're going to briefly review amiodarone, its metabolism and its indications, understand how amiodarone affects thyroid metabolism. But for us to do that, it would be good to do a small review on just thyroid hormone physiology. And then we'll talk about the various dysfunctions that are out there from amiodarone, whether it's amiodarone-induced thyrotoxicosis or amiodarone-induced hypothyroidism. And we'll briefly talk about how these dysfunctions are managed. So I think whenever I think of a medication, it's always interesting to know how the medication got to be used or got to get its fame in the world of, whatever practice it is. And amiodarone actually was initially derived from a plant which belongs to the same species as the Spanish carrot. And this was back in the 1930s. It was used in Egypt to treat various conditions, particularly urinary stones, which is sort of interesting because that's not something it's often used as today. But it wasn't until the late 1960s when a Russian physiologist was able to extract or identify the precursor to amiodarone is called kelin. And how he found that was effective was that he used it to treat one of his technicians who was complaining of angina. Now, when you look at amiodarone, it has gone through various formulations. On the picture right there, and A is the plant from which it is derived. But over time, it has been used as seeds, as various tinctures, medical tinctures, and currently now we have it in the form of tablets. But it has evolved in its way. It has been applied in medications and in treatments of various ailments. But as we know, right now it is currently used as an antiarrhythmic medication. And that actually stemmed from the cardiologist, Dr. Singh, I think. He was working under Vaughan Williams, who was his mentor at that point in time. And he was trying to understand the effects of various antiarrhythmic medications on the cardiac tissue. And what he was particularly interested was in amiodarone. And he postulated that it had a similar effect to sotalol on the cardiac action potential. With that postulation, it gained a lot of interest among the world of research. And in 1969, actually, it was shown, amiodarone was shown to have some good antiarrhythmic effects on rats. And in the 1970s, it was used to treat various ailments in patients. There was actually publication that it was effective in the treatment of Wolff-Parkinson syndrome. And with that idea, more research was done on various supraventricular tachycardias, and they noted that it was quite effective. However, with gaining interest or expansion its use, they were noted to have, the medication was noted to have side effects on patients. Subsequently, given the increased recognition of amiodarone as a good antiarrhythmic agent, it became FDA approved as an antiarrhythmic medication in 1985. As we know, amiodarone is a very effective drug. It is effective in both atrial arrhythmias, and as we know, the Heart Rhythm Society has a very good guideline on how to use amiodarone, particularly in patients with atrial fibrillation. But you can see that when all other medications fail, or when we don't have a lot of options, our fallback is often amiodarone. So it speaks to its effectiveness in treatment of atrial arrhythmias. But we also know that amiodarone is one of those medications that is very important in the treatment of ventricular arrhythmias, whether it's prevention of recurrent arrhythmias. However, it has been shown that it is not as effective in prevention of sudden cardiac death in patients who have ventricular arrhythmias, but we still use them just to keep ventricular arrhythmias under control. So for us to proceed with understanding amiodarone, I would like to talk a little bit about just the metabolism. I'm sure most of us know this, but we'll just review that briefly. Sorry. So when you take oral amiodarone, its bioavailability ranges. It is metabolized in the liver. And so as you can imagine, it might have interactions with other medications. And it is excreted through the biliary tract. And as you know, it has a very long half-life. For a single dose, it can be up to 10 hours. And for chronic dosing, it stays in the system for up to 3 months after discontinuation. In patients who are obese, it tends to stay in their systems a lot longer because this medication is lipid soluble. So before we understand the effect of amiodarone on thyroid dysfunction, it's good to just briefly review the physiology of thyroid synthesis. And I would like to bring your attention to the various processes that are involved with thyroid hormone synthesis. I'm going to talk a little bit about each of these processes, but in summary, there is synthesis of TSH in the thyroid, in the anterior pituitary, which then stimulates the synthesis of thyroid hormones, which goes into the system and has various metabolic effects. Like I mentioned, TSH is synthesized in the anterior pituitary gland and is released. It works on the thyroid gland. And this is a little big picture of where the effect happens. So it happens in the thyroid follicular cells, which is composed of several thyrocytes and as well as a colloid solution. So iodine, which is in our system, is taken up by the thyroid cells, excreted into the colloid section of the follicular cells. And basically, with the assistance of TPH, which is one of the hormones, TPO, I'm sorry, which is one of the hormones of thyroid synthesis, iodine is coupled with this big molecule called thyroglobulin. And then it is taken into the cell where it is broken down into T4 and T3, but mostly T4. And then it is excreted into the system where it goes into circulation and it is carried by various hormones. T4 is then converted into T3 in the peripheral tissues, whether it's the kidneys, the muscles, the liver. It's also, it's done through the effect of the enzyme, the iodinase, and I'll tell you why that's important in a second. So we can see in summary that iodine is very important in the synthesis of thyroid hormones. Why that is important is because when you look at amiodarone, there is this structural similarity, but that is not actually the crux of how it affects thyroid function or thyroid dysfunction. Amiodarone contains a large amount of iodine. About 37% of amiodarone is comprised of iodine. Why that is important is because when we give each patient amiodarone orally, about 37%, like I said, contains iodine. So that means for each 200 milligram tablet of amiodarone that is prescribed, it contains about 75 milligrams of iodine. Only 10% of this is released as free iodine, which is used in the synthesis of thyroid hormone. But that is relevant because for each tablet that a patient is exposed to, or 2 tablets, it releases about 7 milligrams or 50 milligrams of free iodine into the system. And that is significantly above the optimal iodine that we need in the system. And it is because of this excess of iodine that we sometimes have thyroid dysfunction. But before we proceed to see how, the iodine or the amiodarone causes thyroid abnormalities, there are times where there are some changes in the thyroid levels or the thyroid panel that may look abnormal, but it is actually okay. And this picture actually summarizes that. So when you start off a patient on amiodarone, oftentimes you might have changes in the TSH and T4. And that is because of the physiological effects of iodine iodine and amiodarone on the various metabolic pathways. So in the short-term therapy, as we can see over here, in the short term, within 3 months of starting amiodarone, we noticed that you might have an increase in TSH or thyrotropin, a slight increase in T4, a slight decrease in T3, and an increase in reverse T3. And that is basically explained, if you can recall about the mechanism, the amiodarone actually, or the increase in iodine in the system actually has sort of an inhibitory effect on the synthesis of T4. So as you know, T4 has a negative effect on thyrotropin. That's why once there is a decrease in T4 because of the significant increased load of iodine, there is a slight increase in TSH. In the system, you know, the deiodinase enzymes, there's the hepatic deiodinase and the pituitary deiodinase enzyme. And that is also affected by amiodarone. And so you might have a subtle increase in T3 because inhibition of that enzyme, which is involved in conversion of T4 to T3, might lead to an increase in reverse T3. Now that is in the short term starting therapy for amiodarone. Long term, it tends to normalize eventually, but again, you might have slight abnormalities which may not be that clinically significant. So that's just something that we need to pay attention. Obviously, the reason we're talking about this is because thyroid obviously has an effect on the heart, and it affects the heart or the cardiovascular system through a conglomeration of effects. It affects the cardiac vasculature, as we can see to the right here, and it also has an effect on the heart muscle because of the receptors that they contain. And indirectly, it also affects the risk factors for cardiovascular disease, whether it is lipids or inflammatory cytokines. Now we're going to go down to the meat of our discussion. So that we're going to talk about the amiodarone-induced thyroid dysfunction. And there are actually two flavors. We have amiodarone-induced thyrotoxicosis, where you have an excess of amiodarone, and there are actually two types, type 1 and type 2. And then you have amiodarone-induced hypothyroidism. We'll start off with amiodarone-induced thyrotoxicosis. This is one of those diagnoses that it really varies based on where you are. And the prevalence between both of them is sometimes hard to ascertain. In areas where you have iodine deficiency or iodine sufficiency, especially in the developing world, you have about a 6% prevalence of amiodarone-induced thyrotoxicosis in patients who are taking the medication. But then in areas where there is deficiency of iodine, surprisingly, the prevalence actually is higher, which is sort of interesting and counterintuitive. The diagnosis between type 1 and type 2 can sometimes be challenging, and I'll explain why that is in a second. We often see patients not in the state of immediate diagnosis, but usually in the later phases when they have been diagnosed. But generally, we know some of the signs and symptoms of amiodarone or thyrotoxicosis. You have people who have weight loss, tremors, low-grade fevers. But some of the signs can actually be very subtle, and in older patients, you might not actually perceive them. And interestingly, they mention these cardiac signs, which can sometimes be counterintuitive, because if you're treating the patient with atrial fibrillation and they present with atrial fibrillation, you might not, it would be hard to really determine if this is because it's of failure of therapy or poorly controlled AFib, or patients are not responsive to amiodarone. And that's why we have this labs or blood work that can sometimes clue us in as to what is the trigger or the cause of this cardiac dysfunction. Like I said, when I look at the cardiac signs, I'm sometimes baffled because amiodarone is used to treat some of these presentations, whether it's atrial fibrillation or tachycardia. And believe it or not, it sometimes helps with angina. So the first one is going to be type 1, amiodarone-induced thyrotoxicosis. And these are usually in patients who have some sort of pre-existing thyroid disease, whether it is subtle or overt. And it's the second, or the iodine load, that actually pushes people into thyroid toxicosis. It is based on the Job-Basedow phenomenon, where because of an increase in the iodine in the system, the thyroglobulins, or the thyrocytes, are pushed to synthesize more thyroid hormones. And that's why you have an increase in the thyroid hormones. In type 2, usually patients tend to have normally functioning thyroid. So unlike type 1, these are people that when you check, their thyroid glands, they're actually normal. But it's more of an effect of the cytotoxic effect of amiodarone on the thyroid follicular cells, which are the cells which are important in the synthesis of thyroid hormones. The mechanism as to why this happens is not clearly known, but these amiodarone tends to trigger an inflammatory response. And in the process, with the damage that happens to the thyroid follicular cells, there is release of preformed hormone into the system, as well as hormones that are involved, or enzymes that are involved in the synthesis of thyroid hormone. This is important to distinguish between type 1 and type 2, mainly because it really affects how we treat these patients, or our approach to treating them. But in practice, it is not as easy to distinguish between type 1 and type 2 amiodarone-induced thyrotoxicosis. While the thyroid function test might be helpful, it's not always clear. And the other thing that is challenging is that sometimes patients might have actually a combination of both, and it's more of a clinical assessment that helps us get to that. But there are tools that we have, and usually we rely on our endocrine colleagues and our nuclear radiology colleagues to help us assess that. One of them is the radioactive iodine uptake test, and it can usually, in patients who have type 1, it could be elevated, but that does not mean that if there is not increased uptake, they don't have type 1. So it is not a very helpful test, but it can sometimes point you in one direction over the other. The other thing we have, or the other tool we have, is biochemical testing. And in this case, it is the inflammatory marker, or inflammatory cytokine IL-6, or serum thyroglobulin. Like I said, with type 2, there is some sort of inflammatory response. And so you would expect these to be higher in patients with type 2. And obviously, with the breakdown of cells, there's release of thyroglobulin, which is an important component of thyroid follicular cells. You can also do antibody testing, and that would be more specific for type 1, with a particular pointing towards Graves' disease if the TSH is elevated. But something that has really gained, another tool that has really gained more ground in trying to determine or differentiate between type 1 and type 2 is color flow Doppler, where, with color flow, you can actually visualize or assess the structure or the patterns of blood flow and suggest or make a diagnosis of one over the other. So in summary, these are some of the clues that might help you differentiate between type 1 or type 2 amiodarone-induced thyrotoxicosis. So if you have underlying thyroid abnormalities, obviously it might lead you towards type 1. With color flow Doppler, with increased vascularity, you might see, it might point towards type 1. And the radioactive iodine uptake, like I mentioned, could be increased in type 1. But again, if it is normal, you cannot rule that out. Thyroid autoimmune antibodies would point towards type 1. They did mention something about the timing of amiodarone. I don't really know how specific this is, but the thought process is that patients who usually have a short onset of symptoms or abnormalities within initiation of type 1, you can sometimes think it is type 1, but that could also be type 2. Interestingly enough, in patients with type 1, again, this is where I think that the difference is important, is knowing that spontaneous remission is usually not easy. And then ultimately, when you know the difference, you can then target your therapies towards treating them, whether it's thyroid, anti-thyroid drugs or steroids. But we'll talk a little bit about how to approach this again, or what the guidelines show us in terms of managing patients who have amiodarone-induced thyrotoxicosis. Now, this is the grading system by a different society, American Thyroid Association. And before we go into some of the guidelines, I just wanted to put before you what they think, or what they would classify as, based on the type and the grade of recommendations. So there is the strength of recommendation and there's a quality of evidence. So according to the American Thyroid Association, when you're trying to manage patients with amiodarone-induced thyroid toxicosis, it is important that before you start the medication, you want to actually assess thyroid function test before and within 3 months and subsequently. I think most of us tend to do this, although the evidence is at least according to American Thyroid Association is low. I think in clinical practice, most of us are pay attention to changes in thyroid functions. In patients who develop thyroid toxicosis, there is a strong recommendation to engage cardiology in helping determine whether there is a need to continue amiodarone or stop amiodarone. And I think this is very reasonable, given that we are the ones who prescribe amiodarone. So it is really up to us to think critically about whether it is important for a patient to be on the medication if it is causing them to have some sort of disease like thyroid toxicosis. Also, there is a strong recommendation. Remember, I had mentioned clinical. Yeah, so there is, in patients who may have diagnosed amiodarone-induced thyrotoxicosis, it's also important to try to identify what may be the underlying cause with imaging, like I had previously mentioned. And then there are sort of two ways you can target the treatment of this dysfunction. With type 1, the focus should be on thionamides, or in this case, they say methimazole for type 1 because of that autoimmune component. And then for type 2, because of the inflammatory component, they recommend steroids. But there are situations, like I said, where, first of all, it might be difficult to actually determine if it is type 1 or type 2. Secondly, in situations where patients might not be responding to one therapy, there is a strong recommendation to consider a combination of both anti-thyroid medications or steroids in the treatment of patients with AIT. And ultimately, in patients who do not respond to both the combination of MMIs or methimazole or corticosteroids, there is a strong consideration to refer them to surgery in order to treat this medication, to have the total thyroidectomy. So that was the guidelines by the American Thyroid Association, but the European Thyroid Association also has very similar guidelines in terms of management of patients with AIT, but they include another medication, sodium perchlorate, which has an important role. But my guess is that why it is not one of the strong recommendations in American Thyroid Association is because of the side effects. And, obviously this is not a medication we use, but one of the side effects can be life-threatening, which is aplastic anemia. So it requires someone who has a bit of expertise before that is prescribed or managed. So that is really the summary of the difference in the treatment. So when we go back to our patient that we saw at the start, they did a color Doppler flow, and it seemed most consistent with type 1 amiodarone-induced thyroid toxicosis. And he also had enlarged thyroid partners that was suggestive of Graves. But then when you did the thyroid stimulating antibodies, it was normal, and the thyroid peroxidase antibodies was normal. So, this is where, again, we probably need the expertise of our endocrine colleagues to sometimes guide us in trying to understand which is this type 1 or type 2. So that is amiodarone-induced thyroid toxicosis. So we're going to shift to amiodarone-induced hypothyroidism. There's not much I can say about this, just because it is not as concerning as amiodarone-induced toxicosis, but it's also has a low prevalence in countries that have low iodine, and surprisingly higher prevalence when in places where there is a high dietary iodine uptake. Unlike amiodarone-induced thyroid toxicosis, it really does not matter the dose or the frequency. It can really occur with any sort of amiodarone in the system. And as you can imagine, it is more patients who are older and usually female tend to have a higher prevalence or susceptibility, for amiodarone-induced hypothyroidism. And the management is not very complicated. And the guidelines out there just suggest that, there is no strong emphasis to take away amiodarone, but more importantly, it is all about replacement. So you can continue to treat with amiodarone, but if you think that amiodarone can be withdrawn, there are times for there's a possibility for remission or resolution, or spontaneous resolution once it is taken out of the system. But ultimately, you're going to treat this as you treat any sort of hypothyroid condition. So again, these are some of the takeaways I had in trying to just understand amiodarone-induced thyroid dysfunction. Type 1 tends to occur with patients with pre-existing disease. Type 2, normally functioning thyroid. And even though the distinction between type 1 and type 2 amiodarone-induced thyroid toxicosis can sometimes be challenging, but it is important to make that distinction if we can, because it can really affect a treatment guidelines as well as the outcomes. And I think ultimately, we as cardiologists should obviously be involved in the decision making about withdrawing amiodarone, because it is our medication, and it is because of us that the patients are dealing with this thyroid dysfunction. So yeah, thank you. That's all I had for you this morning, and I would be happy to take any questions or entertain any personal experiences that people may have with amiodarone-induced thyroid dysfunction.
Thank you, Will. Good review of an important topic. So about 10, 12, maybe years ago, maybe a little bit longer, we got a little bit excited because they came out with a new medicine called dronedarone or Multac. That sort of the theory behind that drug is it was amiodarone without the iodine, and therefore had less potential thyroid toxicity. As you can probably guess, it sort of fell out of favor, probably due in large part to, it's not completely out of favor, but it didn't replace amiodarone, I think, as we had initially hoped, likely because it's not as effective as amiodarone. So I guess when you as you're going through this, did I don't know, did you come across any, like sort of other alternatives or things you can switch to in these sort of situations, someone who really needs amiodarone or antiarrhythmic therapy?
So Williams, that's a very good question. And to be honest with you, I did not really look into the Maltec, or I did not see any alternatives. I think that the sense I got out of this was in patients who have this dysfunction, it's a question about determining risk and benefits, because most oftentimes I think when people are on amiodarone, it's because it's usually a last ditch effort. But there are times that, patients who are studied in the ICU, there is not much consideration. Patients are discharged home. We can always think critically about whether the patient needs to be in amiodarone or whether we have an alternative. But from what I was able to read, I didn't see any other alternatives in patients who have failed other therapies, and the last option was amiodarone.
Hey, well, yeah, I think I can contribute there just a little bit. So we had a patient at Grady that had been on amio for like 2 years, and actually came in with thyroid toxicosis. And for him, he had failed prior agents, and so it really brought up this conversation. And especially in the hyperthyroid, the AIT population, stopping the amiodarone, from what I had read, isn't always an obvious choice. Obviously, the half-life being so long brings no immediate benefit when you stop it.
Correct.
For the patients that are actively symptomatic, stopping the amio can actually exacerbate the hyperthyroid symptoms and signs, because you start to lose some of the beta adrenergic effects, and some of the structural similarity between T3 and amio can lead to increase, the intracellular effects of T3 itself on receptors and whatnot. And there's some thought too that amio can block some of the T4 T3 conversion. So for the patient that we had originally stopped it, at least on the idea that continuation of the amio will prolong the time to euthyroid, and increase the risk of recurrence for patients that have previously been hyperthyroid. Our patient ultimately got his thyroid out, and in the long run may end up back on it. We switched him to sotalol, which was a reasonable option for him, fortunately. But that was actually a really interesting case for us, because our patient actually, we couldn't get him out of fib RVR, and he had a severely reduced EF in the context of all of this. So ultimately, what endocrine at Grady did was therapeutic plasma exchanges for about a week. And what you would observe is, after a session, the thyroid hormones would drop and then kind of rebound just sub-maximal from the prior session. But session after session, he gradually got better rate control, and then was actually spontaneously converted overnight, and actually went to the OR back in sinus. But the conversation about stopping the amiodarone is separate, but almost harder than what do you use in place of the amio, because stopping it isn't it seems intuitively the obvious thing to do, but isn't necessarily
The best.
without its own issues.
Well, Dustin, thanks for that perspective.
Will, how long was the patient in your case? How long had he been on amio before he started having issues?
Yeah, so he started amio in November, and in March was when we first noticed that he had undetectable thyroid. So about 3 to 4 months.
Yeah, from what I had read, you're right. That's kind of a gray zone where type 1's a lot earlier, and then type 2 is often seen 1-2 years later. Correct. A quarter of that population actually will develop AIT after stopping the amio, and even.
That's interesting.
I mean, just the other thing is my experience a lot of times, and I'm sure our EP colleagues and heart failure colleagues probably seen this more. Yeah, my experience when I've seen this in folks, unfortunately, it's a lot of times in folks that need to be on amiodarone, sort of end stage heart failure patient with incessant VT, and amiodarone is about the only thing that quells them. So you can get into those difficult situations where your options become extremely limited. So
Stan Sherman, just a quick question about dosing. Did any of the guidelines talk about the fact that after they've been on it chronically, to try and cut down on the dosing, maybe even minimize the dosing since it's so long acting, in terms of trying to prevent these toxicities?
Dr. Sherman, unfortunately, I do not see anything in the guidelines mention that, but I think that's a good point.
All right. Well, thank you, Will, for your review, and thank you to everybody for tuning in this morning. And we look forward to seeing everybody next Friday morning.
The preceding program is copyrighted by Emory University.